medicine and urgent care practice here on State Road 70 in Bradenton. Some of you may know me, some of you probably don't, but thank you all for coming today, especially with the bad weather. The subject of our talk today is going to be diabetes, diabetes mellitus, and also obesity. They're often mentioned in the same sentence, and people have questions about both of those. But I'm going to kind of gear the talk a little bit depending on where the interest in the group lies in terms of where we're going to focus most of our attention. I understand the format for today's talk is that I will speak for about 35 minutes or so, and then we'll go ahead and ask any questions you have. And we'll do the best we can. Some questions may be better or more appropriately suited for you and your physician because it will involve some private and protected medical information. So if we can just try to be generic and general, we'll try to cover those types of things. And at the same time, I don't want to violate anybody's medical privacy and whatnot. Any questions before we get started? Okay. Well, I have some questions, so I'll start. Anybody here who is a diabetic? All right. Anybody here who lives with, knows, or cares about somebody who's diabetic? Okay. Okay. So I have really 4 goals that I want you guys to walk away with today, specifically, or more particularly associated with diabetes particularly, is that diabetes is a life-changing diagnosis. It's not a life-ending diagnosis, but it is absolutely a life-changing diagnosis. And it's something that's going to affect you and the people you live with or care about for the rest of their lives. And you, as the patient or family member or friend with diabetes, have to understand that, from this point forward, things are going to be different. And by acknowledging that and embracing that and maybe making some minor lifestyle changes or comprehensive changes in understanding, you can live a long, happy, and fruitful life as regards to diabetes. One other question for those that are diabetics, and you don't have to answer this, but how many people here who are diabetic know their hemoglobin A1C? You can just tell me today. 1, 2, 3. Okay, good. There are several different ways that we test for diabetes. And the one that we typically associate, or people most often think of, is when they get their finger pricked, a little drop of blood, and they check to see what your blood sugar is at that moment. Sometimes they also test your blood sugar when you get your annual blood test or regular screening labs, and that'll be your blood sugar or blood glucose. And those are useful tidbits of information, but it's very limited. When you prick your finger and test your blood, it is your blood sugar at that moment, right then and there. It doesn't say what your blood sugar was 20 minutes ago, nor what it is 10 minutes from now. And one thing we have to understand is that throughout the day, throughout the week, throughout the month, your blood sugar is constantly changing. So we as clinicians or providers, when we help you manage your diabetes, the tool that we most rely on typically is your test called the hemoglobin A1C. And the hemoglobin A1C is a different way of measuring. I won't go into the science of it, but it is essentially a way of measuring your blood sugar over an extended period of time, typically about 3 months. And that's what's really important, because you want to know your average blood sugar throughout that time. We can't possibly check your blood sugar. Well, I guess we could check your blood sugar every 20 minutes of every day for the rest of your life, but it's not terribly practical. So we use this hemoglobin A1C measurement, and that's an important thing for you as a diabetic to understand. The hemoglobin A1C, for most diabetics, is the benchmark of how well your treatment is going. A lot of people will know their height, they'll know their weight, they may know their blood pressure, but they don't focus on their A1C. And if you're diabetic, that's something you really need to know about. So I encourage you and I implore you that if you're diabetic, learn your A1C and keep that as part of your understanding of who you are and how you live your life, because that's very, very important. Having diabetes will change every aspect of your life. indicator to you and a warning sign that we need to make some changes and perhaps prevent yourself from becoming a diabetic. Because as we said before, it is a life-changing diagnosis. People who have diabetes have high levels of circulating sugar, which over time causes damage to the blood vessels throughout your body, the organs that rely on the blood that's supplied by those vessels, and you get end organ damage, which leads to diabetic neuropathy, vision changes, problems with all of your organs in your body. I don't want to be too specific, but your kidneys and so forth. So by show of hands, real quick, do we want to tend more toward talk about the weight component, or do we want to talk more about diabetes? Anybody? Who wants to talk more about weight loss or weight concerns? Who's more interested in diabetes and that kind of stuff? Okay, so we'll kind of stick in that direction. So here's a quick question for you. Do diabetes medicines cause you to gain weight, lose weight, or none of the above? Stay the same. Any thoughts?
Stay the same.
Well, it depends. So it's really exciting. This is the golden age of diabetes. So if you're ever going to have diabetes, now's the time. If you had diabetes 20, 30, 40 years ago, there are very few options for treating diabetes. However, since then, there has been a plethora of new medications and new mechanisms for these medicines, which have provided us with substantial options that we never had before. And the important thing is that some of the older medicines definitely did cause weight gain. So you'd often tell a patient, well, hey, I want you to get things together. I want you to eat healthy. I want you to eat salads and exercise and whole grains and avoid the sugar, lose some weight. And oh, by the way, the medicine I'm giving you for your diabetes is going to cause you to gain weight. So that could be a concern for people. And we still use those medicines because a lot of them are very good. And I actually have a handout I'm going to give everybody before you leave regarding the categories of medicines that we currently use. And I'll try to explain that to some degree to everybody. It may go after the end of the program, but I'll be here for a while if we want to. With the medicines that we take, let me get back for a second. For people who are diabetic, we tend to classify them in different ways. And one way we can classify a person with diabetes, well, as I said before, there's non-diabetic, there's pre-diabetic or borderline diabetic. Then there are what we call diet-controlled diabetics. And then we have people who require medications. And then within those medications, we have people who take oral medicines and those who take injectables. And I'll get into that in more detail in a minute. So some people will get their blood tested and they find out that they have diabetes. They're within that range. And they change their lifestyle. They eat really healthy. They start decreasing their simple carbohydrates. They decrease their sugars. They eat more salads or exercise more. And just those lifestyle changes alone, you're able to maintain your blood sugar level where it needs to be and you don't require medication. That's what we call a diet-controlled diabetic. And really, it's a lifestyle-controlled diabetic. I wouldn't say diet-controlled, because that's really not a fair term. It's more than just what you eat. It's what you do as well as what you eat. So then the next step are, the vast majority of people are taking oral medications. And that's where we have a huge variety of medications that we can consider. I like to take these medicines and break them into two broad differences, or two different categories. There are those medicines which will, first off, they all cause your blood sugar to decline, to go down. They decrease your blood sugar. Some do it irrespective of how much food you've eaten, and some do it dependent on what your current blood sugar level is. And that's really important to you as a diabetic or as a family member for a diabetic, because people who take the medicines that just drop your blood sugar, irrespective of what your current sugar level is, are at risk for hypoglycemia. And hypoglycemia is one of the greatest risks for people with diabetes. Yes, we're always telling you we need to improve your blood sugar and decrease it, but there's also a risk of going too low on the other end. So has anybody here ever had a hypoglycemic event where we got shaky and got chills and foggy and confused and disoriented or passed out? That's hypoglycemia. And that's a really big deal. Right? It's actually a potentially life-threatening emergency. The neat thing is it's really easy to treat. You just need some sugar. Now, I know I just told you not to eat sugar. There are exceptions. As we learn in medicine, there's few rules, and then there's a lot of guidelines. Yes, of course, I don't want you eating glasses of sugar water or tubes of sugar on a regular basis, but in a hypoglycemic emergency, that's really important. The reason I bring this up is that those of you who take diabetes medicine, do you know if you take a medicine that can cause hypoglycemia, or do you not? Do you know anything about the medicines you take? Anybody? I used to. A little bit? You used to? Okay. So you will not be quizzed on the names of medicines, but one of the medicines we see the most of that people use that can cause this low blood sugar are a group we call sulfonylureas, and they've been around for decades. It's one of the older classes of medicines, and they work really well. They can definitely bring your blood sugar down. So if you have a medicine like glipizide, glyburide, any of those types of medicines, those will, if you take that tablet, it will bring your blood sugar down. It has no mechanism for evaluating what your current blood sugar level is. It's going to bring it down no matter what. So if you haven't eaten for a day or two, and you take that medicine, it's going to lower your blood sugar and possibly lower it too much. And that could be, well, those events that you already experienced. And we don't want that again, right? There are some benefits to these medicines. They're very simple. They're very well understood, and very important to your insurance company. They're exquisitely inexpensive. And they love medicines that are inexpensive because they don't want to have to pay for things they can avoid it. Anybody know any other medicine that used for diabetes that might bring your blood sugar down too much?
Sometimes metformin does it.
Yes and no. It can't bring it too much below what you've already eaten. I mean, it's dependent. It can only lower sugar based on what you've eaten. But if you haven't eaten a lot, it can bring it down to where you would be as if you had not eaten. So, but the big one that we worry about is insulin. Anybody here use insulin medications? Okay. So insulins are great. They are terribly important and necessary for a lot of people. Anybody who is a type 1 diabetic, you don't really have a choice. Your beta cells, your pancreas don't function at all, and you absolutely need to have insulin. For people with diabetes type 2, we generally try to use other agents before we go to insulin, just because it's a more complicated medicine to use, although it's very effective. And it's important that you, the diabetic, understand how your insulin works. And I said in the very beginning part that this is a life-changing diagnosis. This is where you have to become the captain of your destiny. You have to really, really educate yourself on the mechanisms of the medicines you're taking and understand them well. So there's new classes of medicines, and I don't expect you guys to know them because unless you're a clinician or you write prescriptions regularly. There are a group we call, well, somebody mentioned metformin before. That's not one of the newer ones, been around for quite a while. That's a class of medicine we call it biguanide. And pretty much the primary one we use there is it's a medicine we use almost always, at least in the beginning. At some point, somebody uses metformin. It's a great medicine and it works for a lot of people. Does metformin tend to cause you to gain weight, lose weight, or stay the same? Peanut gallery?
Generally it's about the same, but it can have some slight weight loss.
Okay. So metformin is fairly neutral compared to some of the others. Although some people, yeah, it depends a little bit on the person. The newer medicines are a class called DPP4s. There's a new group called SGLT2s. There's a new group called GLP1s. And these are exciting medicines. The downside is that they tend to be more expensive, and your insurance company typically would prefer not to use that if we can avoid it. But for a lot of people, it will provide excellent glycemic control without the risk of hypoglycemia. And that's really the goal. We want to get your blood sugar down and not risk these hypoglycemic events. So generally, if we can transition you away from something that will potentially cause you to go too low and use something that can safely treat it, that's a good choice. But I think it's important that you guys understand those medicines. And that's actually the handout that one of my students in the back is going to give you guys before you leave here. And I encourage you, as I said, as the captain of your own medical destiny, look up your medicines. Find out what is the pharmacologic category, what they do, so you understand how they work. And when we leave today, I'll give you a website where you can go and create an account if you want. It's free. And you can look up any medicine that your doctor or physician assistant, nurse practitioner provides for you. And it's a really great resource so you can understand that a little better, because you really need to understand those things. One other important thing I want to talk about is some other life-changing impacts related to having diabetes. As I said, it's life-changing, not life-ending. But because you have diabetes and you have an increased circulating blood sugar on a daily basis, it also tends to impair your immune system to some degree. As such, diabetics are at higher risk for a lot of other medical problems. So it's very important that you aggressively speak with your provider about preventive medicine or preventative care and preventive treatment. As a diabetic, you should understand that you should see an ophthalmologist or an eye doctor once a year for a diabetic eye exam. You should have a podiatrist, and you should see a podiatrist at least once a year for diabetic foot exams, and we'll talk a little bit more about that if time permits, about why that's so important. And because your health is generally impaired a little bit, you are often eligible for some other preventive medicines that at an earlier age that would not be for the general population, such as very important that you get flu shots, very important that you get the pneumonia shots, and now there's two. Anybody hear of a pneumonia shot yet? Anybody? Okay. You may not be aware that there are now two different pneumonia shots, and they now actually recommend that you get both of those, and that's important because you are at a higher risk for pneumonias and all medical problems. It's also very important to understand that if you get sick, it will throw off your blood sugar, your metabolic demand while you're ill, and that will throw things off. And you've got to be a lot more aware of that when you get ill. And as part of that, if you get a simple infection that a healthy non-diabetic person had, you're at much higher risk for that infection progressing to a very severe infection or spreading throughout your body. So you have to have a higher index of concern if you get a simple infection of any kind, and make sure that you're more likely to go see your primary care physician or somebody else in the event that you do get sick. One real quick, since we did supposed to talk about obesity also, one real quick thought I wanted to mention. People who are diabetics and are obese, and even those that are obese diabetics on medication, every now and again we get a patient who dramatically changed their lifestyle, goes out and loses 30, 40, 50, 60 pounds, or really changes their lifestyle, and their blood sugar comes down. And I've had several patients over the years who I have been able to take off all diabetic medications just by changing their lifestyle. To be candid, it's a very small percentage of people, partly because it requires a tremendous amount of effort on the individual, and it can be very, very difficult to do. But it is possible to do that. Over the last couple of years, they've also recommended for certain individuals with significant obesity and diabetes and or other comorbid conditions that they are now actually considering bariatric surgery as a therapeutic intervention, whereas in the past we didn't really consider that. So it's now an option that's achieving growing acceptance, but certainly bariatric surgery is not our first choice. We would try lifestyle changes, oral medications, and injected medications. So since we talked about the medications before, we talked about oral agents, and we talked about oral agents that will lower your blood sugar versus irrespective of how much you've eaten. And then we spoke about oral agents that are dependent on the amount that you've eaten. There are also different types of injectable medicines we have now. There's a category of medicines that are fairly recently introduced to the treatment of diabetes, which can help lower your blood sugar These medicines are not insulin. So people think that every injectable is insulin. That's not necessarily the case. There's a new category of medicine, and these are the GLP-1s, and they have shown a tremendous degree of effectiveness for helping to lower blood sugar, and they do not have the same hypoglycemic risk that we associate with insulin. So that's important to know. Depending on which one you look at, some are dosed daily, some are dosed weekly. That's for you, the provider, but that's something important to realize. And of those, getting now to the insulins, there are many different insulins on the market. Probably won't be able to answer too many questions about that because they're so tailored for you as an individual. But it's important to realize we have what we call long-acting insulins, and then we have short-acting insulins. This is one way of breaking these apart. So your long-acting insulins typically are something you take once a day, and the goal to that would be to lower your basal insulin, or basal sugar glycemic load on a 24-hour basis. People who take insulin typically test their blood on a regular basis. Those who use insulin typically do it for a long-acting insulin either once or twice a day, occasionally 3 times a day. For people with more advanced diabetes and have very poor beta cell function, they will require a long-acting insulin in addition to a short-acting insulin, which is dosed in association with meals. That gets much more complicated for the individual because you would, in that case, typically check your insulin before and after meals and so forth. That can be very inconvenient for your lifestyle. So a huge part of our goal is to avoid getting to the position where you need to have what we call basal insulin with PrimeCare or mealtime insulin because it's very inconvenient for your lifestyle. So our goal as clinicians is really to help you understand your medical condition to the point that between the medicines you're given and the lifestyle choices you make, you don't need to take insulin 3 or 4 times a day, and you don't need to poke your finger 4, 5, 6 times a day. And if you do have to do that, that you at least understand your condition well enough that you can do that in a safe and effective way. Ideally, as a diabetic, you should be able to go into your appointment with your physician or nurse practitioner or PA, whatever, and you should know almost as much as they do about diabetes because you need to be an expert on diabetes and your health. And you really need to put on the captain's hat and direct your ship where you want it to go. And if your choice is not to take good care of yourself, this is America, you have a choice to do that. Nobody's going to make you do anything. Just realize that there more than likely will be significant medical consequences over time. So that's kind of a general approach to what we're going to talk about. And let me answer some questions. See who has what kinds of questions. Not you, your student. You had a question there.
You didn't talk about whether insulin makes you gain weight or not.
Generally speaking, insulins actually cause weight gain. So yeah, that's a great question. Generally speaking, insulin causes weight gains. And that can make it difficult for the person who's trying to lose weight and also treat their diabetes. So that's a great question. Ask a question. Go ahead.
Now I'm in a pre-diabetic category.
Okay, great.
My fasting glucose is like 129, but
Okay.
my AIC is not within the range to qualify.
All right.
Now, doctors seem to think that Mediterranean diet or one of the diets to lose weight is going to control that.
It's entirely possible.
Because it's been over the last 10 years, because I take a yearly physical, that it's raised, from 98 to 103, and then every year it seems like my fasting glucose has raised until this year it went to the 129 level.
The fasting.
Fasting.
So that's a great question. So what he's saying is he's a pre-diabetic. His fasting blood sugar has been creeping up over the last several years. Your beta cell function for the pancreas has kind of declined over time, and he's getting towards that direction where he may need medicine. And the goal right now is hopefully to prevent that. So, one, can he get to a situation where he won't need medicine, and if so, delay that as long as possible. So the answer is yes. So, as I said before, that diabetes and obesity aren't a direct cause of each other, but they're certainly related. And diabetes has to do with the stress and strain on your pancreas. So if you fairly aggressively work on some lifestyle changes, there's a very good chance that you could get to the point that your fasting blood sugar will come down as well as your A1C. So let's not be so generic, let's be more specific. What are some of these lifestyle changes? Actually, that leads me into something. Great. When I say before that you need to be the captain of your destiny, part of it is getting educated. And nowadays there are dozens of resources out there. And there's two that I brought today. I have no financial connection with either of these. These are just two things that I like. This is a book that I'm a really big fan of. It's called The New Sugar Busters. It's not a new book. It's been around for a long time. It really helped me to understand diabetes pretty well, and also it's helped me personally with eating healthier and so forth. It's written by a group of physicians and author. The first half of the book is all about the science of diabetes, and I think for the general public, parts of it are a little complicated, but if you're interested in the science and you want to read it, go right ahead. The second part of the book, for most people, is the important part. These doctors and authors went around the country and spoke with 5-star restaurants and found all these chefs saying, what's the best thing you can cook that's really healthy for people with a very low glycemic index, a low sugar index. And the whole second half of that book is very healthy recipes. In general, you want to decrease what we call simple carbohydrates, which are your simple sugars, or refined carbohydrates, things such as white rice, white bread, refined sugar, white sugar. High fructose corn syrup is probably the worst thing possibly that you could take for yourself. You want to try to replace those with things that, and there's a lot of different terms for this and a lot of different ways to go with high glycemic. So things such as salads. So there's some rough edge, there's benefits there, but they also metabolically they take more energy for your body to break down. You want to use things such as brown bread, brown rice, whole grain breads, things like that, because you can have just as many calories in 2 different loaves of bread, but one, say the white bread versus the whole grain bread, the body spends a little bit more energy metabolically to break it down. Now, if you eat 3,000 calories a day of complex carbohydrates and salads, you're still eating 3,000 calories a day, and you're still going to be, getting overweight, and you're still going to have sugar issues. But if you can replace it with these things that are metabolically better for you, that can definitely help with that. And then there's a strong connection with your exercise level. Ultimately, the total number of calories consumed and the total number of calories burned in a day is essentially your equation. There are some other changes. There are some other ways of modifying your metabolic activity, but the total calories in and total calories out have a huge impact. A couple small things that they found, there's been some research that shows some benefits. One, and this changes sometimes, but currently, and I may be corrected on this, but currently we generally tend to think of eating in terms of a grazing type thing, whereas we eat several small meals throughout the day, as opposed to starving yourself all day, then having one large high sugar meal or high calorie meal. So your body is better suited to eat several small meals. And one really interesting thing, study that I was reading was regarding not only exercise as relates to meals, but in terms of the time component. And there's been some research that shows that if you have mild to moderate exercise in a short period of time right after you eat, that it tends to kickstart your metabolism a little bit. So what I'd recommend to people is that when you finish your meal, once you have, especially a big meal a day, which for most people is dinner, when you finish your meal, go out and take a walk within half an hour of your meal, and it actually tends to help stimulate your body to metabolize that meal more effectively than if you went and sat on the couch with no control and the cocktail. So and that can be fun, right? For those of us that have a significant other, hey, let's go for a walk around a block. It's funny, we think of modern science, we're so smart, we learn so much. But I was watching one of these old black and white movies, and the people had dinner, and the father of the house turns to the mother and house, okay, let's go for our evening constitutional. And they finished their meal and went for a walk right after dinner. And who knew? There's science to support that was actually a good thing to do. So that was kind of a long answer. Did that kind of get you where you wanted?
Yeah. Now, is there any particular, like I said, like you recommend like a Mediterranean diet, which
there's a lot of different ways of doing it. And the Mediterranean diet has generally two really good components to it. Generally, we tend to have generally a Mediterranean diet tends to have less simple sugars or simple carbohydrates in it. They also tend to have more omega-3 fatty acids in it, which are the healthy oils. And there's been some studies that show not only is it's good in terms of the caloric component, but some of these fatty acids tend to have some cardiovascular benefits that will help your heart as well. And people who have high blood sugar are at a higher risk for heart disease. So by getting the cardiac benefit of the omega-3 fatty acids and the olive oils and so forth can definitely be helpful as well. And then obviously the exercise component is part of that. And sometimes people go with, let's say, a Mediterranean diet, and they eat all the right foods, they eat healthy foods, but they eat a lot more of it. It sort of defeats the purpose. So it's a question of how much you eat and what you eat. But yes, but in terms of one specific one, there's really a lot of different ways that can work, and the trick is to find the one that works best for you. Avoid crazy diets. Like I'm eating the castor oil bean diet, or those crazy things. But anything that tends to show a well-balanced, low glycemic diet, any number of diets can be equally effective, as long as it's something you can find that you can be comfortable with. And again, that book I found to be pretty good in terms of some good. I'm a picky eater, so I like that. Here's another book I brought in for you guys to see. Again, I have no financial connection with it. I just thought this was really neat for those of us that are simple. It's called Eat This, Not That. And it talks a little bit about understanding the foods that we are eating or buying at the stores. And the thing that's really nice about it is for those of us who like it simple, it's just a bunch of pictures. So for those of you who like to keep things really simple, it'll show you actual brand names of different products, and it gives you a view in terms of which are better for you and have lower sugar levels and are more complex carbohydrates and things like that. Next question? You can take one. Yep, sir?
Yeah, someone who, there's a two-part question. Someone who doesn't know the numbers, I'm assuming the only way that you can find out what their glucose or blood sugar is to do a fasting blood test. Is that correct?
Correct.
Second thing is, you mentioned having to see a psychiatrist once a year. Why?
Oh, great question. So when you have diabetes, you have a higher level of blood sugar. You've got a higher level of sugar circulating in your blood at all times. And blood vessels have different layers to them. And the innermost, sort of like a garden hose, it has a really tough outside and then a softer waterproof layer on the inside. The very innermost component of your blood vessels is the endothelium. And that has small pores in it, which allows all the layers have pores in them, but the endothelium is the most delicate, the inside. And these allow your body to deliver oxygenated blood to the different organs, and then to provide oxygen and nutrients to your tissues. And then it allows the tissues to unload waste product to circulate for your body to get rid of. When you have high blood sugar over time, it causes damage to the innermost part, primarily, what we call the endothelium, and it causes damage to your vascular system throughout your body. As that damage progresses over time, your body's ability to provide nutrients to those tissues and take waste away from those tissues declines. As that happens, you tend to be at greater risk for infections in those areas, because part of your immune system is your circulatory process of bringing white blood cells and disease-fighting cells to those tissues. And importantly, as the blood supply to the nerves that go to those different tissues, particularly your feet, which is one of the farthest points from your heart, your nerves to those areas tend to sustain some damage. Over time, you tend to get what we call diabetic radiculopathy or neuropathy. And your ability to perceive a problem in your feet declines. What we see with people who have moderate to severe diabetes is that they can get an injury to their feet frequently that they don't perceive. You may get a cut or an ulcer in your foot and feel no pain whatsoever. And you can get infection, which then begins to spread and grow and get worse. And often with their diabetics, by the time the patient realizes that they have an injury, it's too late to treat them very effectively, which is why in the old days, people whose parents or grandparents were diabetics may have seen that they had their toes amputated or feet amputated, stuff like that. Furthermore, one of the more common issues we see with people developing these diabetic foot ulcers is the weight and pressure on their feet, and you can develop calluses and corns, which will frequently lead to a diabetic foot ulcer, which then can progress to a degree where you have severe damage and too late to really intervene effectively. So by seeing a podiatrist, it helps you, one, kind of evaluate what your nerve function is to your feet, how well you perceive things, and do preventative maintenance or preventative medicine to your feet so that you tend to avoid these diabetic foot ulcers. Very often, a lot of diabetics really benefit from orthotic inserts and custom shoe moldings or specialized shoes to prevent these diabetic foot ulcers.
What about the tingling of the feet?
So the goal is to prevent that from happening. So if you identify diabetes at a fairly early stage and you are able to successfully keep your blood sugar down over time, you will hopefully avoid causing the damage to those nerves. To some degree, when people get diabetic nerve damage, it's often irreversible. And you can't cause the nerves to regrow. So the real goal there is to prevent that from happening. There are some medicines that we can use these days to treat neuropathic pain and the neuropathy, but all that does is really treat the perception of the pain. There's very little you can do to regrow or heal those nerves once the damage is done, which is why it's important to prevent that from happening. Yes, ma'am.
You talked about other injectables. The other injectables, are they for type 2 diabetics, or are they also for type 1 with the insulin?
I can double check, but the last time I looked, I believe they are all indicated for type 2 diabetes only. Now, the science probably would support that they could help a type 1 diabetic, but they're not indicated for that through the FDA. Can you check that while we're talking? Check Trulicity, Victoza, anyone, double check that. But my understanding, last I looked, they're almost all, if not all of them, are for type 2 diabetes specifically. Great question, though.
What is to avoid the most, carbo or sugar?
Okay, great question. So carbohydrates really are a type of sugar. Well, sugar is really a type of carbohydrate. It's the most simple form of carbohydrate. So when as carbohydrates break down, they break, without getting into organic chemistry, but carbohydrates are these long chains these long molecular chains. As your body digests them and breaks them down, they get into smaller components. And sugars are essentially small chain or certain long chain types of carbohydrates. They're just very, very simply broken down metabolically. So to answer your question, a better question is, should most avoid would be the simple sugars, because that's the most offensive of the carbohydrates. Did that answer better? Okay. So the real thing, let me give you let me not do the politician dance. Let me give you a real answer. Your number one thing should be to avoid refined sugars. That should be pretty much your number one overriding goal. Of those refined sugars, the very worst is the corn syrup type, high fructose corn syrup. Thank you. At least somebody can say it. So those are the worst. The next worst thing would be your simple carbohydrates, and as opposed to your complex carbohydrates. Is that a better answer?
Yes. They used to say that you should replace sugar by Splenda. But apparently today, Splenda is just as bad as sugar.
Yeah, I'm not a biochemist, but those things get very complicated. There have been a lot of studies, and I can't give you a great answer on that because when sugar substitutes first came out, we thought the world is saved. I could eat all the Splenda or Equal or whatever else, and it doesn't matter. And I think the data doesn't really support that, it's not quite as bad perhaps as a simple sugar in terms of metabolic action, but the way, I went to a conference and explained it this way once and see if this helps. The way these sugar replacements work is that they create a molecule which is structurally very similar to sugar, so that your body perceives it as sugar and it feels like sugar to the body, and oh, it's sweet, it tastes great. The problem is there's so much like sugar that your metabolic process and those that relate to diabetes kind of perceive it very much like as if it were sugar, although it's not. And then there's always the ongoing question, long-term with these chemicals, is there other risks that we haven't quite seen yet? And I will admit, I'm an offender. I drink diet sodas, and probably they're really not good for us. But there's just not a tremendous amount of research to verify that. But there's not much research right now that shows that the sugar replacements lead to significant long-term benefit. There is research that shows that if you compare a natural sugar, such as sugarcane sugar, like the brown sugar or the pure sugarcane sugar, and if you compare that with corn syrup sugar, what is it called again? High fructose corn syrup. There is evidence to show that people who take the high fructose corn syrup sugar, even if they have identical amounts of sugar, the people taking the corn syrup will have a significantly increased weight gain that the regular sugar will not have the proportional weight gain. So there is a disproportionate weight gain with the high fructose corn syrup, which I thought was a pretty interesting study. But,
Is there anything naturally you could take in place of prescription medicine that lowers your blood sugar? Like in a health food store, I know that they.
Well, I'm sure if you go to the health food store, they have a host of things that can help. As a person with a medical license, we're kind of restricted to things that have significant double-blind scientific studies with large numbers of people. I have not seen, and I could be, maybe an endocrinologist out there or somebody else will tell you otherwise. I have not seen any significant scientific studies that meet the criteria that we would typically use in a published journal that would indicate anything has a significant improvement. They probably have some improvement, and it could very well be that they do help. But the problem is that these studies cost millions and millions and millions of dollars, and it could be there's just not the financing to do the study that would prove it. So I'm not going to say they don't work, but I can say I haven't seen any studies that we would consider acceptable that would show proof. Yeah, if it did, I'd probably take it myself. You had a question. One of you have a question?
So is the best, what do you say? When you have bout of hypoglycemia, is the best thing to do is take sugar?
So that's a great question. So first off, you have to understand, are you at risk of hypoglycemia? And that's important. So if you are at risk for hypoglycemia, it's important that you and the people around you get to understand the warning signs of hypoglycemia, and also in terms of what you would feel, and then what somebody who's looking at you would perceive. Because a person who's as having a hypoglycemic episode, one of the first things that happens is you get an altered mental status. So you're asking the person who can't think clearly to know that they're having a problem. It's sort of like talking to a person who's in severe alcohol syndrome. Yeah, you become very confused. Prior to going to PA school, I was a firefighter EMT, and we would often go on an ambulance to people who had altered mental status or were semi-conscious and so forth. And I can tell you from personal experience, when you show up on the scene and somebody is totally out of their mind, confused, and aggressive, confrontational, combative, you will think they're on some horrible drug or significant alcohol like this. Sometimes it's just their blood sugar, this hypoglycemic event, and all you do is give them some sugar, get their sugar into normal level, and suddenly they're the nicest person in the world. And I have had a couple of occasions where we've responded to car accidents where they're about to arrest the person, take them to jail for alcohol intoxication, and you give them some sugar, and all of a sudden they're totally normal. They have other problems. Obviously, you can't drive if you are having hypoglycemic events and passing out behind the wheel. But even to a trained professional, your perception is very different. So your question was, what's the best thing to do to treat it? I went off on a tangent there a little bit. Is that correct? So there are several different things you can do. On most ambulances, we carry these little tubes of glucose. They're little sugar tubes. You can buy them at CVS, Walgreens, Publix, your pharmacy of choice. I've tasted them. They are very sweet, and they don't taste great, but they do work. So you should certainly keep them like that around at all times. One of the other things that I've personally found that seems to work even better is when available, orange juice seems to, and I have no scientific studies to back this up, but I can tell you that when I treated diabetic patients in the home, when we've been able to give them orange juice, it seems to work even better than those sugar tubes. And I can't tell you why. Maybe they drink more of it, they like the taste of it. I can't tell you why it is. But I can tell you orange juice is great. This just is really great for if your blood sugar is dipping too quickly. Very, very, very important to realize that the glucose tube or the orange juice you're taking is a very simple carbohydrate, a very simple sugar. Your body will metabolize that very quickly, and it'll be right back where you started. So it's essential that if you have a hypoglycemic event, that you get some sugar on board immediately, and then also take something that's a more complex food that will metabolize slowly over time. So while you still have the therapeutic benefit of the rapid-acting sugar that you just took, you should also eat something that's, like a sandwich with some, like a real meal type thing. That will give you a level state of blood sugar over a period of the next several hours. I can tell you on an ambulance, in some cases people are unable to take things orally. In those cases, we will typically give them an IV, give them some IV glucose, and within about 5 minutes, they're ready to bring it back to normal. But the idea is obviously to not need to get an IV or something like that. So to summarize that one last thought, I would encourage you and any family members or friends or coworkers to understand the warning signs of a hypoglycemic event and to have some kind of rapid-acting sugar available at all times. And that's really important and a great question.
I would like to add to that point, though, as far as what he was saying, if a patient or a family member is unable to swallow on their own, don't give them a piece of candy, don't put something in their mouth. That's a 911 call.
Yes, if you try to feed an unconscious person sugar of any kind, there's a reasonable possibility that they will choke on it and you will have a considerably worse problem to deal with. So, any other questions? Yes, sir.
What makes your blood sugar go up higher during the night?
How much time do you have? It's a little bit more complicated. A short answer is, there's a couple things. One, you've accumulated, you've eaten throughout the day. So you've got your caloric load from the day is up, and your body's trying to break those sugars down, those foods down in your gut over time. Two, your largest meal of the day is typically your dinner meal. Three, when you go to sleep, your expenditure of energy has decreased. Therefore, your body's burning less calories, your sugar level can go up. And lastly, it has to do with, and this gets a little bit complicated, I don't know if I can really go into that today, but when you sleep, part of your sleep-wake cycle is part of your body's maintenance process, and that as you sleep, your body kind of cycles different chemicals, and it does a lot of health maintenance type things, and as it releases these other normal chemicals that you get in your sleep-wake cycle, it can drive your blood sugar up or down. It depends a little bit on a couple of things, but your chemistry, your brain chemistry changes as you sleep, and it's part of your body's normal process of maintaining general health.
I had been told once too that a lot of times that when you get up in the morning that your sugar will rise just because it's kind of like getting you ready for the day. I don't know if that's true or not, but that's what I was told by an endocrinologist.
Yeah, I mean, this is an unbelievably complicated field of medicine. And as you mentioned that, we have doctors who specialize in this, we call them endocrinologists. They tend to be some of the smarter people in medicine. They tend to be the guys and gals who are like, ooh, pretty smart. You know, the one in med school who seems to stand above the others typically because they really like the science of it. And it is fascinating science. It's really exciting stuff and very complex. And it's kind of fun stuff to learn about. But yeah, it's terribly complicated. You've taken a lot of notes, so you have to have a question.
No, I take notes.
Taking notes for me.
All right. Well, one last thing. You just summarized 3 points that I wanted to cover. Or 3 or 4 things. One, remember, diabetes is a life-changing diagnosis, not life-ending. You can live a long, happy, fruitful life with diabetes. Number one most important thing to understand is that you, the diabetic, or the people in the diabetic family, you need to take ownership of the condition and be a captain of your own destiny. You have more of a vested interest in your success than your physician, your provider does, because this is your body. This is the one body you have, and you've got to keep it working as well as possible for as long as possible. So you need to take ownership of that. Those of you who are diabetic or pre-diabetic should commit to your understanding what your hemoglobin A1C level is so that you can understand your general health of your metabolic processes, your pancreatic function. And lastly, just understand the connection between healthy lifestyle choices, diet, and exercise, which is very cavalier, but you understand the concept of what you eat, when you eat, how you eat, in addition to how active you are, has a huge impact on your overall health over the long term. Anything else?
Injectables only indicate type 2.
Okay, so we did confirm, as I thought, the non-insulin injectable medications are still currently only indicated for diabetes type 2. All right, well, thank you so much for coming. I appreciate it.
Thank you.
Oh, and I have stuff for you. Can we hand out those charts to people?